And it's a great delight to invite David Muchuweti from Harare, who's the winner of the SRS Southern African Prize, to present his paper. David, thank you very much.
Ladies and gentlemen, good afternoon. The topic of my research paper is abdominal surgical site infection, risk factors and treatment in Harare teaching hospitals. Surgical site infection, as we all know, is the most common post-operative complication after abdominal surgery. It increases hospital stay, hospital costs, and it can have a significant morbidity and mortality. As we all know, it's divided into superficial, deep, and overall space according to the CDC definitions. Very few studies in Africa have evaluated the risk factors, frequency, management, and outcome of surgical site infection. So it is for this reason that this study was undertaken. A prospective observational study was carried out in 285 patients who were undergoing abdominal surgery in the general surgical ward as well as in the gynecological ward from the duration May 2007 up to June 2008. Data was collected through pre- and post-operative examination as well as telephone interviews. Inclusion criteria include all patients who were above 15 years who were undergoing elective and emergency abdominal surgery in the two mentioned disciplines. The results: male-female ratio was 1.2:1. Median age was 30 with a rate of 50 to 81. Resident occupations accounted for 21% of patients versus 79% from the urban society. Time of operation: daytime operations were 68%, nighttime operations were 32%. Surgical site infection was noted in 26% of the patients, which represented a figure of 74 out of the 285 patients. There was no statistical significance in terms of the rate of surgical site infection, whether the operation was done as an elective or as an emergency, which means there were other more dominant factors. Most of our infections were superficial, which accounted for about 75% of our surgical site infections. Deep infections were 24%, and organ or space accounted for about 1% of all those patients who developed surgical site infections. Operation by surgical site infection by specialty. If you notice here, 20% of surgical patients developed infections versus 30% of the gynecological patients. From this observation, it would appear that gynecological operations are more prone to infections. But in our study group, the explanation was that the gynecological patients in the higher wound class and they also had higher HIV infection rates. As you can see, most of our wounds were actually clean contaminated up to date, with only 60 patients getting clean operations. Surgical site infection rates by wound class: clean wounds with 90% of infections, clean contaminated 24%, contaminated wounds 23% developed SSI, and dead wounds 44% developed SSI. Half of our patients consented to HIV testing, and the rest declined. So about 141 out of 285 consented to HIV testing. And HIV surgical site infection developed in almost 52% of HIV positive patients, against 25% would develop the surgical site infection when they were HIV negative. So you can see from that table there that HIV resulted in the doubling of SSI. 26% of our patients received blood transfusion, and as you can see, those who received blood transfusion, 52% of them developed SSI, against only 70% who did not receive blood transfusion and who developed surgical site infection. A higher ASA score was also a risk factor of SSI. The higher the ASA score, the greater were the infections in our study. The administration of prophylactic antibiotics in the pre- and intraoperative periods resulted in fewer infections as compared to the administration of these prophylactic antibiotics in the post-operative period, where we had the higher infections. If you can compare those figures, there's actually statistical significance. If we antibiotics were given in pre- and intraoperatively, there were fewer infections. In terms of the detection of SSI, most of our surgical site infection, we detected them between day 4 up to about day 6, which agrees with what is also in literature. And after detection of surgical site infection, management varied from dressing only, in which 11% of patients just received dressings, whereas dressings plus antibiotics, it accounted for about 59% of our patients, and surgical intervention dressings as well as antibiotics was carried out in 30% of the patients. And the outcome, most of our patients healed in less than 30 days, and those who healed after 30 days were 90% and with a mortality of about 7%. So in terms of hospital stay, the non-infected had a mean hospital stay of about 11 days plus or minus 10 days, whereas those who developed surgical site infection stayed in hospital for an average of 22 days plus or minus 10 days. So in conclusion, risk factors for SSI in our environment were a high ASA score, blood transfusion, a high wound class, an HIV infection, as well as delayed use of prophylactic antibiotics. This resulted in an increased nursing burden, more surgical interventions, doubling of hospital stay, as well as an increased mortality. Thank you.
Thank you very much. It's open for discussion.
How's this sort of changed your practice now? Have you started using more prophylactic antibiotics?
Yes, as a from this study, yes, we've actually increased the use of antibiotics in all wounds from clinical contaminated to death wounds, even in HIV positive, regardless of their wound class, we give them antibiotics.
Thank you. Yes?
Bijan Moraj from London. Did you look at all to see which organisms might be responsible for the infections?
Yes.
That might influence the type of prophylactic antibiotic that you use, etc.
Yes, definitely we did that, and most of our organisms were from the GIT. E. coli, non-lactose fermenting were the organisms which are actually isolated.
And are there different organisms from the HIV positive group, for example, compared with the others? Did you?
No, there were no variation in terms of the antimicrobial flora from HIV or from non-infected.
I think it's very important that you have the data. What are you going to do in the next year? What changes are you going to make in practice in the next year based on that? Because the infection rate is high.
Yes, it's quite high. The 50% is quite high. As compared in Europe, it's around 10 to 12% in some countries. So in our environment, HIV infection as well as a high wound class actually major burdens. So in terms of wound class, we use prophylactic antibiotics. As for HIV infected patients, the recommendation is that if it's an elective operation, it's better to delay the operation and evaluate their immunosuppression. If their CD4 count is below 350, it's better to put them on antiretroviral treatment and then put them for operation or evaluation.
And the other one major thing is the timing of the prophylactic antibiotics. There's a little